So now we will discuss about another category of patients who are bleeding while treated with antithrombotics. And when we speak about antithrombotics, we mean vitamin K antagonists, DOACs, direct oral anticoagulants, or antiplatelet drugs, aspirin, clopidogrel, ticagrelor, or prasugrel.
Yes, absolutely. Thank you, Pierre. So I get that when you have such patients, you have first to ask critical questions, and have listed here the critical questions to ask. The first one is to identify which blood thinner or which antithrombotic the patient has between the listed between the antithrombotic that you just listed. The second question is when was the last dose? This is mostly important for antiplatelet drugs and DOACs, and then whether the quantification is possible, because this will give us a clue on how long we will have to wait, on how aggressive we will have to be to reverse the antithrombotic effect. And then finally is the comorbidities of the patient, especially the renal function and the liver function that will be important for the management of these patients. So regarding the vitamin K antagonist, the VKA, they induce a decrease in vitamin K dependent factors that you have here. And the quantification is quite easy, the INR. And the aim is to reverse and to have a target INR below 1.5. That can be achieved quite quickly with the prothrombin complex concentrates, the 4-factor PCC, and you add vitamin K to it. So the dosage is 25 to 50 units per kilo of PCC, in addition to 10 milligrams of vitamin K. For the direct oral anticoagulants, they target either the factor 10A, the xabon, or the factor 2A, the gatran. And their quantification is more complicated, since you can quantify them only with a special anti-10A assay with special calibrators for the xabon, and modified thrombin time for the gatran. And of note, it is important to have in mind that the classical coagulation time that are readily available are not really reliable, since it may change according to the labs, according to the reagents used to measure them. So as I already said, the timing of the last dosing is of utmost importance for these drugs, since their half-life is quite short, around 10-14 hours, and they depend on the renal function and the hepatic function as well. So the quantification may be important, maybe only to have an idea on how these antithrombotics are implicated in the bleeding that we have, and how urgent it is to reverse them or not. For the xabon, we have up to now the 4-factor PCC that should be considered as the reversal agent. The last papers and studies that we have now suggest that the dosage of around 30 units per kilo may be quite effective and relatively safe to treat these patients. And for the dabigatran, there is a specific antidote, the idarucizumab, that you have to give at the recommended dose of 2.5 grams twice. You have all these recommendations are summarized in these publications, and I invite you to go to the to this website here, which is regularly updated with these kind of recommendations that are changing quite rapidly according to the antidotes that will be on the market. And then I will talk about antiplatelet drugs. So that's another issue, an important issue. First, the aspirin and thienopyridines. So as you all know, there is no specific antidote for these drugs. There is no bypassing agents neither. So the only thing that we have is platelet concentrates. But again, the timing between the dosage and the platelet infusion is also important, since you don't want that active metabolites in the plasma inhibits the platelets that you just infuse. And you have here some guidance on the time here: 2 hours for the aspirin, 6 hours for clopidogrel and prasugrel here. And then the quantity of the platelet is also important, and we have to rely on biological endpoint and ex vivo data, showing that probably 1 platelet concentrate is enough to reverse aspirin, 2 for clopidogrel, and probably as much as 3 platelet concentrates for prasugrel. For ticagrelor, it's another story. The point is that although there is no specific antidote yet, the binding of the drug to the receptors is reversible. So you have a steady state between plasma level and the platelet bound ticagrelor. And when you infuse the platelet concentrates, it may be very rapidly inhibited by the plasma level of ticagrelor that is on board. So recent data, and I'm referring to a paper that was published a couple of weeks ago, showed that probably that you will have to wait at least 24 hours before any platelet transfusion may be effective. And thank you for your attention.
Thank you, Pierre. Let's talk about the antithrombotics separately. So
Sure.
First, vitamin K antagonists. We used to administer PCCs to reverse VKA. Do we have real good data, evidence, to show that reversing VKA with PCCs will improve the outcome in bleeding patients?
Actually, this has been investigated in several studies, and that have been summarized in a meta-analysis recently. And actually, there is no difference compared to FFP, for instance.
For clinical outcome.
Yes, for clinical outcome, for death, for instance.
Yes.
However, what is clearly shown is that you reverse much more quickly, and you get the target of below 1.5 much more quickly with PCC rather than FFP. I'm talking about less than 1 hour with PCC compared to FFP.
There are data. There is evidence showing that the speed to obtain a normal INR is critical and associated with a good clinical outcome. Okay.
Yes.
Yes.
So then you can do the association that way. Yeah.
Regarding the DOACs, the direct oral anticoagulants, we are talking about fancy specific reversal drugs.
Mm-hmm.
If, for example, in my center, I do not have idarucizumab available,
Mm-hmm.
Do I need to absolutely have it, or can I use only PCCs, for example?
Yeah.
What's your advice? Do I need to buy these drugs?
Yeah. Well, you know that the need for specific antidotes have been debated, and there is pro and contra against these specific antidotes, and this comes from the evidence that patients with a major bleeding on DOACs have a similar outcome than those on VKA, although there is PCC and other antagonists, and maybe a little bit better even. So the need for these specific antidotes are really restricted to particular situations, and probably that if you are in big centers, big trauma centers, I would recommend to have it for those small situations, but I don't think that it is really necessary for other small centers, and probably that you can go with PCC only.
You didn't talk too much about FIBA, about the activated PCCs. What's your opinion on these drugs? Do we need, again, the same question, do we need to have them?
Yeah, FIBA is a little bit more complicated to have it and to get, and I think that available data are not so clear-cut between FIBA or PCC, And since PCC are more readily available, I would stay on PCC. That's a more simple to have in algorithms.
On your first slide, you told us that we need some information, such as the last dose, the time of the last dose. How do you use it for the management of bleeding?
Well, it happens that in our center, for instance, there was a massive bleeding in a patient who was dabigatran on his drug list, and we gave idarucizumab right away. However, the dosage of idarucizumab who came after the administration was 0, and the patient just did not take his medication. Okay. So he was not able to tell us at the time of arrival. But if we would have this information, we probably would not have give the antidote.
We have a question from Lebanon, Professor Samia Madi-Jebara. She's asking if this situation you describe, is it safe to administer idarucizumab in patients with a very low concentration of dabigatran? Do we have data on that?
We have no data, since the inclusion criteria in the phase 3 trials required that they had certain levels. So we do not have this data. I can personally say that on 2 people in that in that situation there was no adverse events. But I mean that means nothing.
I have a tricky question. It's always the same question. Isn't it a pity that the DOACs have been marketed for more than 8 years now, and we still don't have any antidote for, especially the Xatron? What do you think?
Yes, I agree with you, but you could have asked this question also when the low molecular weight heparins were on the market, because there is neither no specific antidotes for them, and we try with the tools that we have, which is partially effective with protamine. But I agree that specific antidotes that would have come together with the DOACs would have been really a perfect package.
Okay, let's shift to antiplatelet agents. Imagine my patient is taking ticagrelor, is admitted for GI bleeding. So what do I do to overcome this bleeding? What's your procedure? What's your protocol?
That's a tricky question, especially if the patient just come to the emergency room while having taken his ticagrelor 2 hours ago. I think that at least in our institution, we would still give platelets, because I mean, you just cannot do nothing, and all the data that we have is case reports or in vitro data. So we keep in mind that it might be different in real life situations. So we would give platelets, then we would give some other things, probably tranexamic acid, since now we know that it's cheap and effective
and smart.
But that's the main problem. I know that there is some ongoing studies regarding specific antidotes that we hope will be soon available.
There is an epidemic development of antidotes on these new agents. So your point on this is that if the endoscopist doesn't reach an accessible bleeding, like a small artery or something, you use the platelet afterwards. Okay.
Yes.
Okay.
Yes. Absolutely. If there is any mean to prevent and to stop the bleeding mechanically, of course, that's the first thing to do.
In your talk, you didn't mention anything about desmopressin. Is it efficient on aspirin, clopidogrel, prasugrel? This is a question from the chat too.
Yes. Okay. So desmopressin has been studied to reverse antiplatelet agents, and when addressing this issue with biological endpoints, the results are very mitigated. And when you consider platelet aggregation before and after desmopressin, there is almost no effect. However, Desmopressing has the ability to increase the procoagulant surface of the platelets. And it has been shown that it increased by up to 50%, which increased the pool of procoagulant platelets. How this is clinically effective or not, we don't know. That may be a second line option.
We talked about point of care. Do we have a point of care to evaluate the platelet function in patients treated with antiplatelet agents? What are these results? What can we do in a clinical situation?
There is lots of point of care that are able or are deemed to evaluate platelet function. The main issue is that we don't really know how to manage the results of those point of cares. So you will always find a point of care that will give you some kind of results, but that will be very difficult to interpret them. And some studies have implemented them in algorithm, but it's difficult to find out what are the benefit, the incremental benefit of those point of care, since there was always other point of cares such as the ROTEM or other things. So I'm not very confident, and I would not recommend to implement that.
Okay. For example, in the emergency room, sometimes we don't know what kind of antithrombotic the patient is taking. You imagine the elderly patient in a coma, for example. We know that he has a cardiovascular disease. We know that he has an antithrombotic. Do you have a mean to know which kind of antithrombotic he's taking using lab instruments?
Well, using lab instrument, what we do is we perform an anti-10 assay, even with the calibrators with the heparin, or an anti-2A assays, and then we can figure out whether there is an anti-10A or anti-2A, and we do not have anything for the platelets.
Okay, thank you very much, Pierre. We are arriving now. It's already the end of this very interesting session. Thank you very much, all guys. It was about hemostasis, transfusion, and coagulation factors. I have 1 minute to give some take-home messages. So for Julien, the first one is organization for transfusion strategies. Use the products early in the management. Use targets rather than thresholds. Good connections with the lab, and use the POC, point of care devices. For Mark, fibrinogen concentrates not everywhere. The evidence is weak. Fibrinogen level is still an independent predictor of mortality in trauma, okay? Fibrinogen concentrates only in massive bleeding. Are you okay? Okay. For Paul, tranexamic acid is cheap, efficient, reduces mortality, needs to be more widely used. And 1 gram is enough as soon as possible. And last, for Pierre, antidote and reversion strategies are useful, but mechanical and non-specific means are first line. Okay?
Yeah.
Okay, thank you. Thank you for seeing this session. Stay tuned and connected for the next session beginning in 15 minutes. It's a complete session on steroids in ICU with Professor Karim Assenoun. Thank you very much.